Welcome to Clinical Journal Club for this week, first in English. And this remarkable image out of the New England Journal, it concerns a 65-year-old woman who presents with progressive swelling of both hands and diffuse bodily pain. She had a history of lung transplant 8 years ago, and since that time she's received voriconazole antifungal prophylaxis. And what we see here is that remarkable ossifications or calcifications, not always adjacent to joints, but adjacent to the metacarpals and the phalanges and to the tips of the fingers, and also here adjacent to the ulna, and in the other hand, the same kind of remarkable ossifications. I've never seen anything like this either. We're offered hetereotopic ossification, which basically this is, post-transplant calcinosis cutis, malignant fibrous histiocytoma, voriconazole-induced periostitis, and chronic graft-versus-host disease. I suppose all of these are possible and all of these entities actually exist. This is an example of voriconazole-induced periostitis. And you shouldn't take voriconazole every day for 8 years. But voriconazole has 3 fluorine atoms per molecule, and it basically results in bone changes that we called fluorinosis. Probably also protects against getting caries. So that's the correct answer. Now, heterotopic ossifications can take various forms. Post-traumatic myositis ossificans is an example here. This person has received a hip replacement, and we see this periarticular calcification shown here. But in this short display, voriconazole therapy can also produce this syndrome. This is an example of calcinosis cutis after transplantation. Looks fairly nondescript, but in the skin biopsy with the Foncosa stain, we can see the calcification that's shown here. This is an example of malignant fibrous histiocytoma. This is a soft tissue sarcoma. Won't concern us further. And here's another 66-year-old patient with fluorosis induced by voriconazole. And this is a bone scan. We can see changes here in both ribs, in the shoulder joints, around the knee joints where these ossifications take place, probably related to the fluoride content of this molecule. Here's an example of a patient with chronic graft-versus-host disease, and he has a bony problem that's a little more difficult for me to delineate. He's supposed to have a subluxation of atlas on axis. The axis has the odontoid process, you'll recall. In the MRI, I can't really identify it, but it would be in this area shown here. Spinal cord looks okay, but the problem then subsequently could become spinal cord injury due to this subluxation. Now, the first topic in the New England Journal this week is ticagrelor. And you'll remember we discussed this medication last week. This drug is a reversible P2Y12 antagonist that inhibits platelet function, as shown diagrammatically here. Similar to clopidogrel, which is not reversible and which requires a step to be metabolized to an active product using the CYP3A4 enzyme. Ticagrelor would avoid some of these problems. So that's the chemical structure of ticagrelor. And in a Lancet paper last week, we examined a study in which ticagrelor was given to patients with diabetes and stable coronary artery disease. These patients had been subjected to some sort of a percutaneous coronary intervention earlier. And what we learned from this study last week was that ticagrelor does indeed provide some protection from major adverse coronary events, The difference here is an absolute difference of about 2%. It's statistically significant. Overall survival, and in patients that had not undergone PCI earlier, we see no significant difference. But what we also see is an increase in major bleeding events with ticagrelor. The comparator group here received aspirin alone, and the ticagrelor group received aspirin plus ticagrelor, and we see evidence of increased hemorrhage over time. Now, in this study with in the New England Journal, same idea, same drugs, same kind of patient population, but these are not the same patients. But basically, this study is no different. And we see here almost 9,619 patients received ticagrelor plus aspirin. The placebo group received aspirin alone. The vast majority of these patients, 80% in both groups, had undergone some sort of a coronary arterial revascularization. So this study is very, very similar to the study that we've just seen in the Lancet. And what we see here, again, is that ticagrelor plus aspirin provides some improvement in the avoidance of cardiovascular death, myocardial infarction, or stroke, and that's statistically significant. And same kind of curve as we saw in the earlier study that was published in the Lancet, a slight difference of 1 to 2%. That means that the number to treat would have to be greater than 30 patients over a period of time of 54 months. But we also see an increased number of terminations of treatment related to either bleeding or the development of dyspnea. And why ticagrelor should be associated with the development of dyspnea, I'm not certain. The authors couldn't elucidate this any further either. But what we see here is increased bleeding with ticagrelor compared to placebo. Same result as in the Lancet study. And in terms of patients that permanently discontinued therapy, the issue of increased bleeding was significant, and intracranial bleeding was also more common in the group that received ticagrelor. So same messages in the Lancet study. Why there had to be two studies examining this issue, I'm not certain, but that's the story. Now, the next story in the New England Journal has to do with spontaneous urticaria. This problem can be a major clinical dilemma for patients that have this. And this is what this looks like clinically. These urticaria can develop spontaneously, and they're related to IgE molecules sitting on mast cells when whatever antigen that elucidates this problem comes in contact with this complex. These mast cells release a whole lot of mediators that result in these giant urticaria. Now, in this particular study, patients with the giant urticaria were subjected to various treatments. 3 groups received this antibody, ligelizumab, and ligelizumab is a monoclonal humanized antibody against IgE. One group also received omalizumab, which is an already approved antibody against IgE, and the other 2 groups received placebo. So there are 3 different doses of ligelizumab compared to 1 dose of omalizumab, and then the people that got placebo. And here are the groups and a diverse number of subjects, quite a few subjects in this fairly large study, and they're evaluated with itch scores and the severity of urticaria that they have in the presence of angioedema and other clinical aspects, and the randomization seemed to function statistically appropriately. Now, the authors of this paper claim that ligelizumab is better than the reference drug, the other antibody against IgE. And they make this argument based on a statistic involving bootstrap samples that I don't know that very well. But if we look at this forest plot here, it looks like the ligelizumab group does a little bit better than the omalizumab group, although that was not the primary hypothesis in this study. And if we look at these various graphical displays here of weekly hives, severity scores, and other parameters that are examined here in these severity scores, all of these seem to go down, and if there's a clinically important difference here, it escapes me. Then adverse events. There were some adverse events with actually both forms of antibody. These antibodies are given every 4 weeks by injection, and that causes local changes here. And also reported by the patients was an increase in the number of viral upper respiratory tract infections, but severe infections weren't noted. So the bottom line is that ligelizumab seems better than the other antibody that's currently available for this problem, although an actual comparator study here needs to be performed to verify this assumption. Now, the next study in the New England Journal involves screening for tuberculosis in a high prevalence setting. And Vietnam is a country that where there's a lot of tuberculosis. Some of it also occurs in patients that are HIV positive, but there's a lot of tuberculosis in Vietnam. And so what the Vietnamese did in this particular study is they performed a screening intervention to try to lower the prevalence of tuberculosis in this particular province, which is on the southernmost tip of South Vietnam, adjacent to Cambodia, as shown here. And basically what was done here is communities were randomized to either an intervention involving screening of large numbers of people, having them induce sputum to be produced. This sputum was then examined with a genomic DNA expansion test that requires the polymerase chain reaction. And this test, we've reviewed this already in the past, also determines whether or not the strain of tuberculosis is resistant to rifampin. Details are shown here. The control group here was not evaluated unless they had specific complaints and displayed these to a physician. So what we see here, these are households that were randomized, and this study ran over a period of 4 years, large number of patients. We see here 21,000 people in this intervention group and 18,000 people in the control group, and various age group. These are households, not patients. These are households. So the total number of patients here is massive. 42,000 patients in the intervention group, 41,000 patients in the control group. And what we see here is that indeed the prevalence of tuberculosis in the intervention group was reduced, not quite in half, but by a substantial margin compared to the individuals who were placed in the control group, who only were inspected in case they got specific complaints. So it looks like this massive screening program could reduce the prevalence of tuberculosis in Vietnam. And just interested me that in a framework of 70 years between 1970 and today, now the Vietnamese are publishing in the New England Journal. Pretty good. Now the review in the New England Journal involves syphilis. And this is a scanning electron micrograph of Treponema pallidum. And if we just look at this problem, this is the incidence of syphilis in Germany, the 70s compared to the 90s. And then, I don't know if this is probably just a coincidence, a law was passed in Germany called the Infection Protection Law. Since that time, syphilis seems to be increasing, at least in men, compared to women. So syphilis remains to be a problem, and about half the people that show up with syphilis today are also HIV positive. Now, the topic of the New England Journal concerns neurosyphilis, and one of the classical findings in neurosyphilis is posterior column degeneration. a condition that we call tabes dorsalis. And this is here Paul Ehrlich, together with a Japanese associate, developed the first treatment for syphilis 90 years ago. There he's smoking a cigar in this old photograph. So the review in the New England Journal is about syphilis. And the tests that we have available that are have a sensitivity of 100% for neurosyphilis involve the fluorescent teponemal antibody fixation test, has a very high sensitivity for identifying the condition. The VDRL test, which looks for reagent, not that much different from the test that was developed by von Wassermann 80 years ago, has a very high specificity, but the sensitivity is not as great. And these issues are discussed in this particular review. And also the clinical features of neurosyphilis, which has a very protean form of presentation, usually after the primary chancre, but it can manifest itself years and years, 30 years later. General paresis, which is a progressive dementia associated with neurosyphilis. About half these patients will have an Argyll-Robertson pupil. And you may remember that the Argyll-Robertson was a Scottish physician who observed that the pupils in these patients do not react to light, but they do react to accommodation. So if you move your finger closer to the eyes of these patients, their pupils will come down, but if you shine a light in it, they don't come down. That's the Argyll-Robertson pupil, and the Argyll-Robertson pupil is seen at about 90% of the patients with tabes dorsalis that also have this posterior column problem, so that they can't walk properly and develop Charcot joints. These are classical manifestations. Then the tests I've already mentioned, the tests that we apply, cerebrospinal fluid should be one in these patients, and some of the tests have a sensitivity of 100%. The VDRL has an excellent specificity, but it will be negative in about 30% of the patients. Then the treatment really hasn't changed very much. 50 years ago, the treatment consisted of benzathine penicillin. That's still the best treatment for people that are allergic to penicillin. Ceftriaxone and other alternatives are available, although penicillin is still the best treatment. This is the patient from last week that also had this peculiar ossification around her knee joints. Might occur to us that perhaps voriconazole could be responsible for this also. But this condition is called synovial chondromatosis, and the röntgenographic manifestations are shown here. And then the next patient in the New England Journal, We're back in business. The next patient, so Übertragung läuft, Aufzeichnung läuft auch. This patient here has what we called Landolfi's sign. This patient had acute aortic insufficiency because of an aortic aneurysm involving an aortic dissection. And if you go into the New England Journal and you click this image, you'll observe that with systole, the pupil comes down, and with diastole, the pupil goes up. So there's systolic constriction of the pupil with diastolic dilatation of the pupil. And that's sometimes seen in patients with aortic insufficiency, and that's called Landolfi's sign. There are also a dozen other signs that are associated with aortic insufficiency. Don't see these too much anymore because we identify people with aortic insufficiency before they develop a pulse pressure that's wide enough to manifest these signs. Corrigan's pulse is common. Quincke's fingernails are common. Traube's sign, de Rosier's sign, and these various other signs that you can memorize if you're into these sorts of things. And Landolfi's sign, systolic contraction and diastolic dilatation of the pupil. Then the patient in the New England Journal is actually the same patient that we discussed in the interactive session that we did last week. So it's the same woman. This a 60-year-old lady that comes in with various complaints with a history of gastroesophageal reflux and migraines and this information that was given here. But there's nothing in this information that we got last week concerning diarrhea. Now, when we look at the presentation for this week, it also involves copper metabolism. And there are a number of enzymes that I've listed here that you probably can't read, but there are a whole bunch of copper-dependent enzymes in the body. And we absorb about 1 milligram to 3 milligrams of copper daily. There's a copper transporter that's involved with copper transport across the gastrointestinal tract. Copper is transported to the liver, where it's also stored, and it's then released through an ATP cassette transporter. And when this ATP cassette transporter is mutated, copper can accumulate in the liver and also in the central nervous system, which causes Wilson's disease. And copper is transported in the plasma by means of ceruloplasmin. You'll remember all these things about copper. So this patient in this week's New England Journal of Medicine, same patient, here are medications. What we're also told in this presentation is that she has diarrhea, and she has 3 bowel movements per day, whereas her normal pattern was a bowel movement every other day. That means that her bowel movements have increased basically 6-fold, and this was information that wasn't told to us in this interactive case report. So if we look at this woman, the most remarkable things about her is that she has a hematocrit of 12 volume percent and a hemoglobin of 3.8. So she's profoundly anemic. And we're also given her peripheral smear, and you'll notice here her erythrocytes vary. They're unequal in size. For the most part, they're fairly large. Matter of fact, they're larger than normal, but there are also smaller ones. And there's also a variation of shape. So anisocytosis is variation in size, and poikilocytosis is variation in shape. Now, this is not pernicious anemia because her neutrophils are not polylobulated. As a matter of fact, this is a stab neutrophil. So her neutrophils are not polylobulated. So this is not pernicious anemia, and this is probably not folic acid deficiency. And there are various laboratory values here that corroborate that point of view. So a bone marrow is done, and this bone marrow evaluation shows evidence of bone marrow arrest. So she's not producing erythrocytes appropriately, because with a hematocrit of 12, she ought to have a reticulocytosis of 15–20%, and her reticulocytosis is only 0.7%. So somebody decides to work up her diarrhea, and there are some images here that are consistent with degenerative processes involving her small intestine, and a biopsy is done, and she actually has evidence of celiac disease. So that explains why her copper absorption is not appropriate. And when her copper levels are measured and she receives copper replacement and also treatment for celiac disease, first of all, her gastrointestinal villi improve remarkably when she's placed on a gluten-free diet, and her hematocrit also increases. She also develops an episode of alveolar hemorrhage, which can be also associated with this process, and that's called the Lane-Hamilton syndrome, in case you're interested in that. So that was that patient. Now, another paper in the New England Journal involved epidemiologic signatures in cancer. What does the author mean by an epidemiological signature? Unterschrift. I have no idea, but basically what this is about is how the epidemiology of certain forms of cancer has changed in the United States. And this isn't all the United States, these are only some United States where registries are conducted so that this information could be accrued. But I think it's quite interesting. Let's look at Hodgkin's lymphoma, for instance. Hodgkin's lymphoma, the incidence of Hodgkin's lymphoma hasn't changed at all since 1975 to 2015. The incidence remains flat. However, the treatment for Hodgkin's disease has decreased the mortality by about 65%. And that started in 1975 when I was a junior physician, and it's improved to the present day. So if we look at the relative rate reduction, it's even more impressive. So there have been great strides made in the treatment of Hodgkin's disease. I think we knew that. Now, if we look at chronic myeloid leukemia, the incidence of that hasn't changed one iota either. However, 1995, 6, 7, and 8, there's a remarkable reduction of mortality with the introduction of imatinib, which is a specific treatment for chronic myeloid leukemia. We might imagine that. Now, lung cancer shows a different pattern. Lung cancer has decreased in men, probably because they're smoking less, whereas lung cancer has increased in women, probably because they're smoking more. And this is the kind of epidemiological information that the authors refer to as cancer signatures. Now, stomach cancer has decreased substantially in incidence and decreased also in terms of mortality, probably because of effective treatments for Helicobacter pylori and the way that foods are processed. Cervical cancer, because of screening, I assume, and perhaps more recently because of the introduction of an appropriate vaccine, the incidence has decreased substantially and the mortality has also. Colorectal cancer, also decreasing in incidence, probably because of improved detection methodologies. Thyroid cancer, the mortality and metastatic incidence of thyroid cancer has not changed since 1975, whereas the incidence has increased to a certain degree, primarily in women, although the mortality has not changed. Renal cancer, probably because of serendipitous detection, because of ultrasound imaging, etc., the incidence has increased. Mortality has remained flat because treatments have improved, in my view. And if we look at the relative changes in these things, we can see that in these graphs down here. Malignant melanoma incidence increasing continually, probably because of detection, perhaps also because of climate change and more sunshine, I don't know. But the metastatic incidence and the mortality have remained fairly flat and have actually improved to a modest degree, although substantial improvement could be made here. Breast cancer in women, the authors assume the incidence has increased because of increased screening. Mortality has decreased. A lot to be done here because I think the decrease in mortality is not that dramatic. Prostate cancer, with PSA screening, marked increase in incidence, mortality, so la la, perhaps over-detection plays a role in these patterns. So if we look at all cancers in men, little modest increase in incidence, modest decrease in mortality, substantial room for more improvement, and all cancers in women, somewhat similar pattern. So that's signatures of cancer, epidemiological signatures. I guess that's what the authors mean. Now we move to the Lancet. And the first paper in the Lancet is again by Salim Yusuf. He has good connections to what we now call middle income countries. So this particular study was performed in Colombia, in South America, and in Malaysia. And it involves a community-based comprehensive intervention to lower blood pressure and lipid values in large communities in these countries. So basically the intervention here involves not a polypill, actually involves 2 tablets. One of the tablets is to lower blood pressure, consists of an ACE inhibitor or a calcium channel blocker in case the people start to cough on the ACE inhibitor, and it also contained a diuretic. And then the other tablet contained either atorvastatin or rosuvastatin in low doses. For reasons that aren't clear to me, in Malaysia, this treatment costs $5 to $8 presumably per month, and in Colombia it costs 3 times that much. But I can tell you from my experience in the United States, the cost of these products in the United States are at least 10 times that much. So here we see that various communities that were here randomized to control or intervention, and how far they had to walk to get to the center, and the number of clinics, and all sorts of other interesting tidbits of information. And the surprising, this will knock your socks off. Blood pressure went down, and cholesterol went down. Why wouldn't they? We know these products function. And so if we look at this forest plot, it's a little different. The 0 reference point is over here, and the products worked in all these various different groups. Didn't matter whether they went to university or didn't finish school, but everything else was markedly moved to the left. LDL cholesterol went down, blood pressure went down. I guess that's not surprising. So hooray for that study. Now the next study concerns biodegradable polymer sirolimus-eluting stents against durable polymer everolimus-eluting stents. Now these are called second generation stents, although we know that stents are not genetic, but these are more modern stents. So this is not the issue of whether it's a bare metal stent against a drug-eluting stent. We're past all that. So we're now looking at biodegradable stents versus stents that are not biodegradable. Now you might think, well, why is this interesting? And so if we look at these, some data on this, this is the polymer coating in this sirolimus elucidating stent, and there's been substantial changes in how these stents are designed and processed, and looks pretty impressive. And in JACC cardiovascular interventions, I've found a study that compared durable polymer stents against biodegradable stents. These are scanning electron micrographs. And if we look at the number of platelets stuck onto vessels, the durable polymer stent doesn't look that bad. So we look at the results of this study. And 649 patients in one group and 651 patients in the other group, and whether or not they got ticagrelor or prasugrel or clopidogrel, that was all distributed equally in the groups, and most of them received ACE inhibitors and beta blockers, and these treatments seem to be fairly standardized, although I'm not quite sure why only 14% in both of these groups got a statin. But at any rate, the randomization seems to have worked. And if we look at the maximum pressure that was applied in these stents, I guess there was a statistically significant difference here, although I'm not certain that 13.49 atmospheres is that a clinically relevant difference between 13.82 atmospheres. So it looks like the pressures were pretty equal. And if we look at this Bayesian analysis, I didn't really understand it. But basically, the authors argue that the resorbable stent is better on the basis of this Bayesian analysis. And if you're an expert in this, and if you know something about Poisson distributions, you can look at these distributions, but I wasn't that impressed. But at any rate, the durable polymer everolimus stent had more target lesion failures, although the difference here is only 2%. That means number needed to treat is 50. And the biodegradable stent looks like it's a little different. Cardiac deaths are not statistically different. These are all relative risk ratios, not p-values. And whether or not we would be able to detect this clinically in our patients, I'm not certain. But the authors argue for the biodegradable stent. And here's a forest plot looking at the differences. So this is an example of two modern stents compared. The next study in the Lancet involves the treatment of heart failure. And in this study, men were compared to women. Now, I think most of us appreciate that there are some differences between men and women. And one example happens to be volume of distribution and bodily surface area and size. So the argument here is that perhaps the heart failure treatment for women might be inappropriate compared to men. And here we're concerned about heart failure with reduced ejection fraction. So this is basically systolic heart failure. And there have been a lot of various studies that were done over a period of 30 years that were analyzed in this massive meta-analysis. And so if we look at these heart failure studies, first of all, it looks like the women do better than the men anyway. But at any rate, the recommended beta blocker dose could probably be reduced to 60% compared to the doses used in men. And that would be enough, because if the women get too much beta blockers, their mortality from heart failure seems to then again increase. And the same is largely true for ACE inhibitors. So women might be appropriately treated with a half the ACE inhibitor dose that they're currently getting. And probably the same is true for ARBs compared to the doses that are applied in men. And here again are the beta blocker doses. So that's the gist of this study. So perhaps we're overdosing the women that have heart failure with reduced ejection fraction compared to the doses that are applied in men. Now, the two reviews in the Lancet concern type 1 diabetes. And the first one concerns gadgetry. And unfortunately, they didn't show pictures of these gadgets, but there have been wonderful things that have been developed in the last several years that operate as sensors so that blood glucose levels in patients with diabetes can be measured online with one device for months. Otherwise, these things can be placed subcutaneously. Some of them can be placed with a simple surgical incision. This one lasts for months, and these patients then can read their blood sugar values on their telephones and direct their insulin replacement therapy accordingly. And the numbers of blood sugars that they have that are within the range is substantially improved, and the number of hypoglycemic episodes are also reduced accordingly. So the devices that are available are much better than what's been available in the past, and patients with type 1 diabetes should surely be outfitted with these. And what we'll see in the near future are closed loop treatments where the insulin pump is also driven by the device, and then the patients probably won't even have to look at their telephones. And the next review in the Lancet concerns changes in the Lancet. What? Oh, shit. Jetzt läuft's hier auch nicht mehr.
Yes.
Concerns, what the authors call this changes in the landscape. And the landscape of type 1 diabetes involves type 1 diabetes risk, which is largely immunological, because this is basically an autoimmune disease with antibodies against various constituents of beta cells. And it also involves risk that's perhaps provided by the administration of cow's milk or other environmental factors that are involved in the development of type 1 diabetes, and strategies to try to ameliorate the development of type 1 diabetes, or perhaps avoid the expression of type 1 diabetes altogether. And we've looked at a study relatively recently involving an antibody against CD3 expression, which inhibits CD8 lymphocytes from producing these antibodies. And these various previous studies involving avoiding cow's milk or bovine insulin or gluten-free diets and the nicotinamide these various things are reviewed here. And lastly, the administration of certain antibodies. And we can classify the patients in USA and Europe, and who has a high-risk genotype. Those are people that have first-degree relatives of type 1 diabetes that could perhaps be monitored, and if they have an antibody profile, then a specific treatment could be given. And then the various interventions that have been applied in various studies that are listed here. And with this antibody, the hazard ratio of it then expressing the phenotype of type 1 diabetes can be reduced, perhaps over a period of years, which would be a substantial benefit for these patients. So the hope is that in coming years we'll be able to reduce the expression of this phenotype so that patients that are at risk for type 1 diabetes would have a better outcome. So that's the conclusion from this particular study. We'll close with this case in the Lancet. It's a 23-year-old Japanese lady who claims that a white string has been emanating from her anus. And her history is that she's eaten raw fish, which is not that uncommon in the diet of Japanese. Now, in this ultrasound examination, and I think this is remarkable, the ultrasonographer identified this structure in this ultrasound examination. So endoscopy was done, and this looks like a tapeworm. And the fish tapeworm, it has the genus Diphyllobothrium. And the fish tapeworm that's seen in Europe is seen mostly in Finland. That's called Diphyllobothrium latum. But here, this Diphyllobothrium is endemic in Japan. So the doctors had to figure out, how do we get this entire tapeworm expelled? And I was interested in what they did. They fed the patient gastrografin, which is a diatrozoate contrast agent. So the tapeworm swallows the gastrografin, and if you then do studies, you can see a gastrointestinal examination not of the patient but of the tapeworm. And with this technique, they were able to ensure that the scolex, that's the head of the tapeworm, the binding part, I guess that's here in this little red box, is also expelled, so that we're sure that the tapeworm is gone. And the expulsion of the tapeworm was successful, and then the lady's complaints were alleviated. Thank you for listening. That's it for this week. If you'd like to hear all this business in German in 15 minutes, you can tune in again. Thank you. Oh, next week I get a week off, but I'll have the file in the internet, and in 2 weeks we'll make an amalgam of what's been presented in the New England Journal and the Lancet. Thank you for your attention.